medicine and the cream corn seed in stripes. When they were
Hello, hello. All right, class, come to order. I'm Jim Piles from Washington. I'm here to help. Asking me to be practical and provocative is like pouring gasoline on a fire, as you may determine for yourselves. I must say I was very impressed with both presentations, particularly Aaron's presentation, but it did not come as a surprise to me to hear that the hospitals in Colorado are doing joints. That did not surprise me.
That is so bad.
I would ask her to remember, though, that my son is trying to get into medical school, and he wants to go to medical school in Colorado, but that's just I don't have any conflict of interest, as we heard earlier. Oh, yes. Let's see. I'm the most low-tech person you've ever seen. All right, you'll see that my slides are not as good as everyone else's, but I'm just an attorney. And I have the distinction of never in my life having provided a single episode of home care. But I advise a lot of people who do, and have done that all my life. I'm here to report, though, a little bit on a care delivery model that we've been working on for some time, as some of you know. It's called the Independence at Home program. It's actually a statutory provision that's already in the Medicare Act as a demo. And as I will discuss later on, we're 2.5 or 2 years and 11 months into that demonstration, and it's looking like it is phenomenally successful. And it is a model that takes primary care into the home, supplemented by home health. And there's no reason why home health can't employ the doctors, have the nurse practitioners, because either one can do this kind of care. But it looks like it is going to show just tremendous savings. And we're talking, CMS will not let me say what those savings will be, but they seem to be truly extraordinary. And I like to refer to Independence at Home as the 15-year overnight success, because getting this through CMS has been like pushing a chain uphill. It is real, and we have a participant in the audience here, but who can attest to that. I mean, he's 19 years old. You wouldn't believe that. Let me see if I can get this to work. Okay. What? Oh, there we go. All right. One thing I thought, a common theme that I've heard through both prior performances is the opportunity for home care, particularly in the area of high-cost patients and chronically ill patients. And I can tell you, I've been in this business for 43 years, folks, and I have never seen an opportunity like this, because we are now, the whole healthcare delivery system is being changed in this country with the Affordable Care Act, and it is being changed to put financial risk onto insurance companies who can no longer avoid sick people. They can no longer base premiums on health status. And they're in deep trouble, frankly. I refer to the insurance industry these days as the walking dead, because I just don't think they will survive this or can survive this. We'll see. But every insurance company in the country now has an interest in finding out where their sickest patients are, who are their sickest patients, and how to reduce those costs. And you're in the business of providing low-cost care. So you are perfectly position. All you have to do is take what you do, package it in the right care delivery model, but you have got an extraordinarily bright future. I know, so you've been in the wilderness for a lot of years, but you're about to hit the promised land, I'm telling you. And that's what we're seeing with Independence at Home. That program now started as a demo on June 1, 2012. It is now in every single state in the union, and commercial insurance plans are snapping agreements up like crazy. And I thought what would happen is we would just enter into contracts with Independence at Home programs and health plans. Little did I realize that some insurance plans are not stupid. They just bought them themselves. Centene just a couple of months ago, bought up U.S. Medical Management, which is one of the biggest providers of Independence at Home style medicine in the country. So they just bought it for themselves. I mean, they know how to bring risk control in-house. So the other thing I've seen, too, is we've had our trials with Independence at Home and getting them paid their savings share. But I found it really interesting that the hospital-based and integrated delivery system models are having trouble with their boards saying, when are we going to get paid? We can't support this much longer without getting paid. The investor-owned models, investors are saying, not a problem, keep going, doing what you're doing. We'll just keep pouring the investment dollars in. So I will just tell you, one of the things that I've learned in 43 years in health law and policy is follow the money, because the money is going in the direction of lower cost care to high cost patients. One quick question, quick point on the GOP and the Affordable Care Act. The last thing that the GOP wants, and I predicted this some months back, is for the Supreme Court to invalidate the subsidies in King versus Burwell. If they do that, Justice Roberts will put a Democrat in the White House in 2016 because it's going to be their problem to fix. And so I think, from what I'm hearing now, just yesterday I saw this report, that the Republicans in Congress now no longer want to repeal the Affordable Care Act because so many Americans like it. So also, just a couple of quick items that are not in the PowerPoint. New England Journal of Medicine just came out with a report. Pioneer ACOs saved 1.2%. Woo! 1.2%? These are the best ACOs in the country. These are systems that are entirely committed to this model, who have all the people who know what they're doing. They're determined to make this a success. 1.2%. Other thing, private equity firms. This is just in Modern Healthcare Today. Private equity firms are buying up primary care practices so that they can resell them to folks who are integrating this practice. It's like a commodity. They figured out what I figured out some time ago. Guess who the gatekeepers are? The primary care practitioners. Guess who you have to get close to if you're going to succeed? The primary care practitioners, because you cannot prescribe. That's a big problem with home health. So the marriage made in heaven, primary care together with home health. In my humble opinion, as I say, maybe it's provocative, but I tell you, I'm just telling you, you got to find some way to unlock the money. Okay, so I was one who adhered strictly to the outline. So, I was told to talk about measurement, cost, quality, and savings. Which is the most important? Cost and savings, absolutely. This on section 1115A-C is the statutory authority for the Innovation Center. The Innovation Center has the authority by Congress to extend programs that reduce spending without reducing quality, or those that improve quality without increasing spending. What they cannot do is they can't expand programs that increase spending without reducing quality, and they cannot extend those that improve quality and increase spending. You can't do anything without savings. That's it. You just can't do it. You can't go anywhere. And ACOs, I just don't think they're too big to fail. And I don't mean to blast ACOs here, but I mean, who knows? They may succeed. And Independence at Home is a program that is completely compatible with ACOs and the patient-centered medical home. They just happens to concentrate on the highest cost patients. Now, the second highest performing Pioneer ACO in the country got almost all of its savings from an Independence at Home program. $3 million a year, one program. Okay. So a word about quality. As George Tyler, a good friend of mine at the Washington Hospital Center, says, everybody knows what quality is, whatever I think it is. When someone tells you that quality is the most important thing in the coming 5 years, and it's not really cost, it's really quality, you know you should be looking for another consultant. Because I don't care how much quality you improve. If it doesn't save money, that dog won't hunt. It's just not going to happen. And also quality measures. I just recently went through a round and round on with someone over quality measures. What should they be? How many should we have? In Independence at Home, we have 14, 6 affect saving share, but there's a total of 14 because I sort of understand. Years ago, when I was working with home health, you're a $2,300 benefit. We spend more than $2,300 trying to figure out what to pay you. We have, what is it, 153 ways to figure out how to spend $2,300? I mean, get real. So the idea is, in my view, was you're going to have a program that saves money. You better keep it simple. So let's look at what some of the other programs. How many quality measures for ACOs? We have 33. They originally suggested 65. When I saw that, I said, this is going nowhere. No one's going to sign up for that. And no one did. Not a single one. Not even the demo. The folks in the demo, the group practice, physician group practices, so all said they were going to exit if we had 65 quality measures. So they cut it in half to 33, but guess what? It can go back in a heartbeat. And the problem with ACOs, and this is something you should watch for if you enter into any contract, they can change, CMS can change the quality measures at the end of any year. So how do you know what you're accountable for? Because the government can move the goalposts on you. You need to make sure you freeze those quality measures for the term of your contract so that you can do some business planning. Patient-centered medical home, 149 quality measures. Are you serious? Independence Health, I said 14, and they cannot be changed during the term of the agreement. So what do quality measures really mean for the provider? It means you got risk, and you probably don't know what that risk is. It also means that the folks who are applying the quality measures can stick their hand in your pocket. So one of the first priorities is get the data from the payer. You've heard that from others here. If you get the data from the provider association, guess what Congress thinks of that data? They think it's worthless. If you get the data from the plan or from CMS, everybody believes that. I mean, that's the gold standard. So when you have savings sharing, which I love to hear that part of these other programs, savings sharing is great because it forces the payer to tell you how much you saved them. That's cool. And if you can get CMS to do that, then you can take that data and go anywhere to another plan, and you can get a contract. So also, let's see here. Okay, yeah, as I say, my approach is, we were supposed to talk about interventions. My approach is find the money. Go where it is. The money, if you look at the way healthcare, Medicare spends money, 50 to 60% of that money is all concentrated in a small percentage of patients. So, and if you want to go appeal to any health plan, walk into a health plan and say, I feel your pain. I know you have to get your costs down where they are, where they're highest. Tell me what your highest cost profile of your patients is. I will get those costs down. If I don't, you don't pay me. If I do, I want a chunk of it. That's a pretty good deal for them. That's what Independence at Home does. So here is just a famous chart that came out of 2005 CBO study. This is what Independence at Home was really based on. See, the top 5% of Medicare patients accounted for 43.1% of the cost. If you look at the top 10%, you're up about 70%. ACOs didn't read this chart. They included also the patients in the bottom 50%, and guess what they account for? 3.8% of costs. If you get loaded with those patients, you're screwed because you can't achieve savings on patients that don't cost anything. No possible way. Cannot happen. So it's all a matter of the population you choose. And I suggest if you're thinking of choosing a population to serve, choose a population that's where the money is. Get a direct reward for your success. One of the Independence at Home programs that achieved all the savings for a Pioneer ACO called us and said, well, what should I do? I'm getting ready to negotiate this contract. Get them to give you the data. Make sure it's in the contract. He did that, and he was able to take that data and get 5 or 6 or 7 more contracts. And then the ACO decided they wanted to shut down that program and go somewhere else. So, but he had the data. So saving share, there's an 80% saving share in Independence at Home. That's the highest you're going to see anywhere. And the 80% is wonderful because it's on top of everything else you get. That's great. But the thing that's more valuable than that is that determination that the payer has to make every year and tell you how much you saved. Because we're entering into a world, we're going to be in it for the next 10 years, where the race is going to go to those who can save money. Get close to the gatekeepers. Already talked about that. Don't chain yourself to a sinking ship. Watch those contracts. Make sure you can get out of them. Because some of these programs, we're in a wild west right now, folks. The pieces are in the air, and a lot of these models are not going to succeed. So you make sure that you get the data and can get out if you need to. So you can go somewhere else. Rethinking roles, as we talked about, touched on this today. Think of yourselves as chronic care coordination providers, not just home health and hospice providers. Diversify out of traditional Medicare. I mean, I hear so many companies say 90% or 80% Medicare. Holy smoke. That means that your future existence, it rides on the judgment of an unelected bureaucrat somewhere in Washington or Baltimore. It really does. And these people don't know what they're doing. I mean, they think they do. They're trying to do well, but they don't have any experience. So here, with a reformed healthcare delivery system and every plan in this country now concerned about cost, you have an opportunity to really diversify. Medicare should be no more than 50% of your business in the coming 5 years. You ought to, and not because you reduce your Medicare population, but because you increase your private insurance population. And employ primary care practitioners. As I said, you know, if investment management or investment firms are buying them up, why shouldn't you buy a few? And now we know that they're allowing, 15 states now are allowing nurse practitioners to do primary care. They're probably a lot less expensive than MDs. Lessons learned. Okay, this is lessons we've learned in the 15 years in independence at home. Fee-for-service bundling, managed care, ACOs, and patient-centered medical homes all have the same problem. They do not want the really high-cost patients because they lose money on them. So if you have a program that provides an incentive to treat the highest cost patients, then that ought to be a pretty successful program. It's something that no one else is offering. So you distinguish yourself in the marketplace. Independence at home, you have to have a minimum savings annually of 5%. If you achieve that, then you get 80% of any savings beyond that. That means that the patients you want are the absolute highest cost train wreck patients because they're the easiest to show savings on and the greatest savings can be achieved. So you want that 5%. And under the Independence at Home program, the criteria we have there for participation actually is capturing that top 5%. Those patients, as Dr. Toller says, you always know when you're an office-based physician when one of these patients walks into your office or rolls into your office, your heart sinks because you know you can't help them. And you know they're going to take up the rest of your day. So what we're finding is current physicians don't mind giving you those patients because they'd rather not have them. These are the lessons learned from 34 straight failed chronic care demos that were analyzed by CBO. It's the last point there. Focus on the highest cost patients. Don't make upfront payments like per member per month. Require minimum savings of 5%. We did not pay them to say this. They came to this on their own. And all those elements are in Independence at Home. So engaging partnerships, stay close to and hire the gatekeepers. As I say, ACOs are not too big to fail, but some of them may be too big to ignore. I mean, you may not have a choice because one thing ACOs do is they allow the ACO to dominate a local market. So one might say, if you were crass enough, you might say they're anti-competitive. You might say that. And some places they really are. So you may not have a choice. You may have to get in there. Think about partnerships with other organizations like technology companies. We represent a number of technology companies, and I can tell you, they want desperately to show that their technology works in the home. So they're very anxious to do joint ventures with you. Surprises or challenges we've had? Working with CMS can be time-consuming. Nothing good happens fast. I've learned that. Calculating the cost baselines is harder than you think, believe me. It is. But the good thing is we have, I think, taught CMS how to do it, essentially. Dr. Conway, the deputy administrator, said in a meeting about 2 weeks ago, for the first time ever, CMS has adopted the suggestions of an association about how they should do cost projection, and that was the suggestion made by the American Academy of Home Care Medicine. We had some gifted people at the University of Pennsylvania who said, hey, look, HCC scores underestimate the cost of the highest cost patients. So when you use UCMS, when you use HCC scores to project that cost, which influences how much cost savings you're going to get, they're underestimating it. So we showed them how to adjust it to get that baseline up. Now all the participants in IH are going to be seeing a bigger cost share. Payment can be slow. Oh, Lord, yes. One of the things I would suggest you do, if you are, we're 2 years and 11 months into this, we still haven't been paid, but we have high hopes. But we really do think that from what we hear, the savings is going to be really significant. I would suggest if you're negotiating an agreement with a private plan, put penalties in there. If they fail to pay on time, they owe you more. It's easy to negotiate up front, hard to enforce later on. And don't penalize past good performance. One of the mistakes that we made in Independence at Home was we said, okay, you are going to be judged by how much you save on the patients, the eligible beneficiaries you enroll. Well, those who enrolled in the program who already had a group of patients they were serving, they had to also have a prior hospitalization within the past 12 months and in order to participate. And what we found was the programs that enrolled had been doing such a great job of keeping the patients out of the hospital. It wasn't post-acute care, it was just non-acute care. They were doing such a good job of keeping them out of the hospital that none of them were eligible to enroll. So we learned that we're going to change that when the legislation, the conversion legislation gets adopted. What I wish I had known, I was asked to address this. In 43 years, I have never seen a model like Independence at Home that got better the more I knew about it. Everything I've ever done in health policy, I've thought later as it got implemented, oh God, I wish I'd thought of that earlier. Independence at Home just gets better and better and better. I'm just stunned. The one thing I've told you there about not enrolling, being able to enroll existing patients, that was the one mistake, which I think we can correct. So essential points, redesign, I would say key is outreach personnel. You've got to let the plan community, the practitioner community know what you do and know you can help them. LinkedIn technology, most of the technology today has been designed for hospitals, not designed for post-acute care or home care. Data analysis is huge, as you've heard. Data analytics and data involve competent vendors based on peer advice. Don't buy the snake oil. Listen to folks who have either used these systems and not liked them or used them and liked them. Seek pilots, devote adequate staff. These are just things we've learned. Risk assessment, I find it amazing how folks go into, well, I will use ACOs as an example. They go into ACOs and have no idea what their risk is. And, it only costs, what, depending on who you talk to, $4 million to $12 million to start one up. So, once you've invested that kind of money, how long is it? You can't get out if you've sunk that much money into it. Independence at Home, the upfront cash to start an Independence at Home program is about $250,000 from what I'm hearing. And so your return on investment probably will be in year one. Issues in forming new teams, corporate practice of medicine, Stark and antitrust laws, CON, licensure laws. One thing we did learn is, as was mentioned earlier, you really need mental health practitioners in that team. So Independence Home, very quickly, I quoted that at the top because a senior staffer on the Hill coined this phrase when I went in and talked to her. She told me about Independence at Home. She said, the reason this is such a great program is because it's targeted, immediate, and proven. I said, oh, I didn't understand that. And what we're finding on the Hill is almost everybody in Congress now knows what this program is, and they love it. I walked into the chairman of the Senate Health Committee's office the other day to talk about something else. And I mentioned Independence at Home. Oh, we love that program. That's just a wonderful program. So Independence at Home demonstration, as I say, it has a statutory provision in Medicare, 15 programs in 12 states and D.C. That's the demo now. The non-demo programs are spreading literally all over the country. 3-year demo starting in June. CMS is saying the savings sharing determinations are imminent any day, any moment now. So, as I say, we think they're going to be significant. This is the VA program that is very similar to Independence at Home. It's the home-based primary care program. It's been operating for 20 years. And they've got tons of data showing that it works, and this is without savings sharing. So it started at about 7,200 patients. It's now up to 34,000, 300 plus locations, 50 states and DC. Look at the results. Reduced combined VA and Medicare costs by 13.4% annually, VA costs by 24%. This is where the costs are highest now. Reduced VA and Medicare hospitalizations by 25%. VA home-based primary care, again, reduced the combined VA and Medicare hospitalization days by 36%. 83% positive patient satisfaction rating, which is the highest of any VA program ever. And they estimate would generate about $6.3 billion in Medicare savings annually, or $63 billion over 10 years. You show that number to any member of Congress and their mouth will water because they always need savings. As Mark Miller of MedPAC said to us when we went in and briefed MedPAC on this, he said, if you show savings like that, there's no power on earth that's going to keep this from being enacted as a permanent Medicare benefit. So Washington Hospital, these are by the way, peer-reviewed studies. The second peer-reviewed study was on the Washington Hospital Center program. You can see similar, somewhat similar savings, although this was prior to them entering the Independence at Home Medicare demo. Important to see, too, they reduced skilled nursing facility days by 27%. But look at the impact on home health. The Washington Hospital Center achieved those savings by increasing expenditures on home health by 58%, increasing expenditures on the hospice by over 100%. So this is where we should be as a nation. We should be looking at overall cost to patient. I don't care, frankly, as a taxpayer, what your profit margins are in home care. You can walk through it barefooted. I don't care. What I want to know is, are you saving me money on patients overall? And what we know is we can dramatically increase the amount we spend on home health while reducing the overall cost of patients. That's the story you have to tell. Look at the VA, home-based primary care program. It increased home health utilization by 425%. That's huge. So there we are. And I'll be glad to take some questions if there are any. Okay.
Questions for Jim?
Jim, to clarify, is it only shared savings that is part of Independence at Home, or is there a PM up front?
There is no PM up front. Everybody gets paid. Everybody gets what they would ordinarily get. Patients get coverage for whatever the benefits are already under Medicare. The practitioners get exactly what they'd be getting, fee for service, episodic payments, whatever they get. It all goes into the base, though. And then you get, on top of that, if you achieve savings, you get 80% of the savings. But you're at risk for achieving that 5% savings during the year. You get no upfront per member per month payment. And the reason we did that, and we also put in a provision that says that if you don't achieve savings of 5% for 2 consecutive years, you're out. So what we wanted to do was have a self-culling process in there so that only successful programs will remain in the program. Well, we keep adding successful programs and dropping out those that are not successful. And one of the things you see that happens when you do that is there's an intense interest in a learning collaborative because everybody wants to figure out who's successful and what are they doing. So it's a rapid way to ramp up. That's a great question, and one we've really thought a lot about. Let me just take a quick shot at it here. Under the ACO model, and again, I don't mean to be hard on ACOs, but under the ACO model, your baseline is computed on a rolling average of the past 3 years of your patients. So the more you reduce those costs, the more costs you're going to have to save because your baseline is going to get lower and lower and lower. Independence at Home doesn't do it that way. We project the cost of patients who are not enrolled in anything. They're not enrolled in managed care. They're not enrolled in Independence at Home. These are unmanaged patients. That's the baseline. So that's, and it's based on, that baseline is constructed on the number of patients of various acuities that you have accepted. So you have a automatically case mix adjusted baseline for your practice, which is based on people who are not getting any kind of managed care. Okay, so what happens then maybe when you enroll all those patients? There aren't any more of those patients left. Well, that'll probably take a minimum of 10 years to do. But if that starts to happen, then all you have to do is pick a base year and trend it forward with the rate of inflation. Anyway, it's, this is what the people at the University of Pennsylvania tell me.
You know, and probably much less scientific, I would tell you, in terms of our organization. Colorado is one of the healthiest states in the country, and so we don't have low-hanging fruit. So even the fact that we are seeing the penetration we are is pretty amazing, because we have to climb up high into the tree to get any kind of savings whatsoever, and whereby there is some concern regarding what Jim just said, there's every intent on going global cap again. Because, you know, I was part of that first wave in the late 90s when providers arterially bled, and we said, we're getting out and we're never getting back in. But we've learned a lot in terms of the fact that you have to have data. Now that we have data available, there's a whole different way of doing things. And so, you know, I would say that strategies are much more direct to employer as well as global risk.
I just finished reading the roadmap, the value-based payment roadmap for New York State, and it talks about the sort of premises around that. From their perspective, they believe that this is going to be so transformative within 5 years from now that, you know, even like things like cost shifting, it's going to be fully integrated. It's going to just totally change the shape of the landscape of health delivery in New York. And they keep talking about how the baseline's going to just keep changing in terms of where the, you know, where the savings are, and that it's going to be transformative in terms of the positive outcomes that are at the end of the day going to be after all of this transformation occurs. So they're looking at it from not just the savings associated with reduced medical and provider interventions, but the whole prevention thing about like just completely changing the, the face of healthcare, the way individuals take care of themselves in the future.
One of the things, I mean, just a bit of advice for you as I've helped clients get into this. If you're trying to decide what model to use, and you should be trying to decide that, because we are going to some sort of value-based models, you should be aware of what the limitations of each of the models is, and what the limitations are, what the advantages are, and just know that on the front end. I think, I don't know, the criticism, for example, of bundling is that you get lots of bundles. If you do a lot of joints, for example, then you're going to get a lot of joint procedures. That's what some of the experts around DC say. And if you're in ACOs, you don't have a whole lot of control over whether how what you get paid lines up with what you do, because the savings could get swallowed up by some other organization in the ACO. So you just have to you have to go into these programs with your eyes open. And think about what the plans and the government want. If they're paying for the services, they want capitation, because in a capitation they take their cut off the top and let you make do with what's left. And so that's a real advantage to them. The good news for you is a lot of patients really don't like it, and practitioners don't like it much either. So I suspect it's already, that idea kind of failed once, but it's picking up steam in the state plans now because it's a simple thing to do. But it is a business opportunity for you, because think of what happens to the participants in a managed care plan. They get a flat payment. So guess who is the most undesirable patient for them? The really high cost people again. So that risk just gets passed down another level. You then get to do the contract with a managed care company. And you can craft that like you want, but I would urge you to think about doing saving share. Again, not just because of the saving share, but because the data they give you is invaluable.
I think one interesting comment that they made about the bundles in this value-based payment roadmap is they said the whole concept of when does the bundle begin. So in our scenario, I'm in a bundle payment 2 where it's hospital length of stay and post-acute. Then I'm in a post-acute bundle, which is all post-acute. They're talking about in this value-based payment roadmap is the pre-bundle. Is the person in the community, okay, getting preventative services? Is the pre-hospitalization? So then they were talking about annual bundles. So when you look at things like something like annual bundles, that's pretty close to a PMPM. You know what I mean? So if not, so it really is. Just sort of moving everything more upstream, in terms of, and what they did say in DISRIP is interesting. Everything ultimately will be in value-based payment except for prevention. So that will always be paid as fee-for-service, because to encourage the, the vaccinations, preventative health screens, and things like that. So they just are really looking to totally transform, care of the community, of individuals in communities.
Great business opportunity, flash. Under the Affordable Care Act, every patient, whether they're in private plans, Medicare or Medicaid, gets an annual screening for chronic illness. Guess what happens when you find the chronic illness? You have to treat it. Guess who gets to do the screening? The providers. Unbelievable. And you get paid for case finding, and that's not a fraud. That's not a fraud and abuse issue. But I sometimes, being provocative, I sometimes like to say, if you really, the most effective wellness program you could have, or preventive care program that you could possibly have, is increasing the speed limit to 80 miles an hour. That would eliminate a lot of chronic illness.
So that is so great that Jim brought that up. How many of you heard the NPR article last week from the physician that was interviewed East Coast who absolutely says no annual prevention visits? That's how we save money in healthcare, because people know when they're sick. Just wait until they come to sick. We're increasing total cost of care by having people come to do their annual visits, which kind of goes to exactly what Jim just said. If you do your annuals, then you have to pay for them, and guess what? You have to treat them if they come.
Actually, that really will happen. My prediction, and sue me if I'm wrong, but my prediction is going to be that we're going to see the incidence of chronic disease in this country over the next 5 years spike. Not because there's more chronic disease, but because we look for it.
Yes, so what's your crystal ball?
Who knew that a Republican-controlled Congress would pass an SGR bill that adds $140 billion to the deficit? I mean, who could have predicted this? I think what we're doing, the only thing, if you're assuming there's any strategy at all involved, one could say that the strategy is to make the Medicare program so expensive that it absolutely has to be dramatically reformed. I suppose you could argue that. But I think where we're heading, and I hate to say this, being someone who's of Medicare age, is well. Let me talk about your opportunity first. The first thing we have to do to reduce costs is to take costs where they're the highest and get them down. That's where you come in. That's a wonderful opportunity. You'll never in your professional careers again have an opportunity like this. This is, as I tell folks on the Hill, this is your last chance, members of Congress, to reduce health care costs without making some very unpopular political decisions. Because after this, if you're going to reduce costs in Medicare further, you're going to have to shift more cost to patients, you're going to have to cut coverage, you're going to have to increase the age of eligibility. All those things we will see. But remember, you are in the position of low-cost providers. There will always be a place for you as long as cost is an issue, and I can't ever imagine a time when it won't be. I tell you, the people who are in the biggest trouble right now are the insurance companies and the hospitals. The hospitals take 40% of Medicare of healthcare spending. So if you're going to save money, where's it going to come from? The doctors are only 20%, and then everything else is less than that. So most of the savings has to come, and the cost reduction has to come from hospitals. And I'm just so sorry to hear, for the sake of my son, that physicians are not going to see the same rise in salaries as they've seen in the future. They're going to be plateaued off. But they won't be cut. They'll be plateaued, and that's what you see with the SGR fix, because they can only go up 0.5% a year for 10 years under that.
The audience, how many of you are participating in the budget? Here, show of hands. I'd say it's a third, maybe a half. Shared savings, fewer, just maybe a couple. And I'll say anything else in terms of payment related to value or quality. So I'm going to lay out kind of 4 options before I'm going to let you take like a 20-minute break or so. So I kind of really liked the large pillars that Aaron laid out. So the first kind of bucket, I'll say, and where I want to see, get a sense from you guys on where you'd like to spend some time, maybe drilling down either with the panel up here and or your colleagues in the audience, because this is all teach, all learn. So the first kind of bucket would be, I'll call it data analytics measurement, kind of the first piece. The second would be consumer engagement, kind of patient engagement. I thought that was a really interesting area to explore further. Third, network management, and I'm going to lump community partners, which is the piece that Rose talked about as well. And that fourth bucket, I'll call it risk assessment and interventions or care coordination. I'm going to kind of put that into the fourth area. Could I maybe just see a show of hands about level of interest for the kind of first data analytics and measurement? Okay, good interest. Consumer engagement. Okay. Network management, community partnerships. Also about similar. And then risk assessment, interventions, care coordination. All right, a little bit lower. All right, so what I'm going to ask you to do is use those index cards. And of those 4 buckets, please think about the questions. I think we got the most around kind of community partnerships seem to be of high interest, but also data analytics and measurement. But please, would you write down your questions that you have? They can be very specific or very general. I'm going to ask you to kind of pass them or leave them on the ends of your tables as you go out for a break. It is 5 till 2 by my watch. Can I invite people to be back by 2:15? The restrooms are on the floor, at least 1 floor up and 1 floor down. So those are your opportunities for restroom breaks. And please be back in 20 minutes, and we'll resume the conversation. Thank you so much.
I can eat it now.
Okay, so panelists, where do you think you want to